All right, let's go ahead and get started. Thank you for joining us this evening. We are excited for this panel. The panel presentation is titled Moving from Practice to Action, a Practical Approach to Advocacy, and made possible through the Society of General Internal Medicine. And I have the honor of introducing our speakers today. So I'll start off with Mark Ernest. He is a tenured professor of medicine at the University of Colorado Anschutz Medical Campus and division head of general internal medicine. He served as the founding director of interprofessional education for the University of Colorado Anschutz Medical Campus and co-founded and co-directed the LEADS program, which stands for Leadership, Education, Advocacy, Development, and Scholarship. This is a program designed to train health professionals in leadership and advocacy skills to improve the health of the underserved. Mark earned his degree from Vanderbilt and a PhD in health and behavioral sciences from the University of Colorado. Mark was a Soros Advocacy Fellow, and his advocacy work has included media and legislative strategies and is focused on expanding access to care for Colorado families, reducing conflicts of interest among providers, and promoting prevention through policy. Also joining us is Renu Tiperneni. Dr. Tiperneni is an assistant professor in the Department of Internal Medicine, Division of General Internal Medicine and Hospital Medicine, and serves as faculty advisor for the Policy Engagement and External Relations team at the Institute for Healthcare Policy and Innovation at the University of Michigan. Her clinical practice includes primary care and hospital medicine for adult patients at Michigan Medicine and the VA Ann Arbor healthcare system. Her research focuses on investigating the impact of health reform policies and programs on low socioeconomic status, aging, and other vulnerable populations, and on delivery of care in the healthcare safety net. Her current work includes examinations of Medicaid policy, including work requirements, integration of behavioral and physical health care, and assessments of social determinants of health in clinical practice. She has evaluated the Affordable Care Act, Michigan's Medicaid expansion, and other state and federal policies, and is a recipient of a KO8 Career Development Award from the National Institute on Aging, examining the impact of coverage expansions on near-retirement adults. And my name is Lilia Cervantes, and I'm an associate professor, hospital medicine, and also in the Office of Research at Denver Health. I earned my medical degree here in Colorado and also completed internal medicine residency here in Colorado. My work is focused on improving person-centered and clinical outcomes among documented and undocumented Latinx individuals on dialysis. And I'm currently on a K-23. My focus is to develop culturally tailored interventions to improve social challenges faced by Latinx patients on dialysis. And so with that, just some quick housekeeping announcements. Let me see if I can move the, oh, there we go. Okay. First, we want you to join the Society of General Internal Medicine. There are a lot of opportunities, including networking with peers and member-based communities. There are programs, we have national and regional meetings, and you can publish and present your work. And lastly, there's a COVID-19 resources page, and so you can read about any of the topics listed here on this slide. And so we'll go ahead and start. We have no conflicts of interest. Mark is a member of the External Advisory Board for the Center for Clinician Advancement on United Health Group. My funding comes from a K-23 and the Robert Wood Johnson Foundation, and Dr. Tiperneni's funding comes from a KO8, Michigan Department of Health and Human Services, as well as the Michigan Health Endowment Fund. And then just to remind everyone that the opinions shared here are our own. And I'll go ahead and hand it off to Mark.
Thanks, Lily. Am I audible?
Yes.
Okay, good. So let me start with our learning objectives, of which there are 4. We'd like to describe a practical framework for planning advocacy, discuss how to and to identify and engage stakeholders and allies, to describe how the framework for planning advocacy led to a policy change using a specific case example, in this case, undocumented immigrants with kidney failure, And then finally, to have you each apply the advocacy framework to a challenge of personal concern to help you develop your own advocacy plan. So if you could advance the slide. So before we dive into that, I want to just plant for you what we're going to come to later, and have you think as we go through this, what is the issue that is most on your mind, most concerning, the thing that if you could go out and get active tomorrow, what would that be? What we're going to do is for the last portion of this is have you take that idea. You're going to join others in a small group, and we're going to have you work through that idea in the context of the framework we're going to do. So I want to just, I want to tee that up right now and have you thinking about that so that when we get to that point, you'll have your issue identified. So next slide, please. So I'm going to spend most of my comments walking you through this graphic. Okay, so this is a framework we developed to teach advocacy over the last number of years. And I want to start your attention with the concentric circles in the middle. So you can see 3 concentric circles. The innermost is labeled individual advocacy. So these circles represent both the target and the outcome of the advocacy work that you may do. And I'd like to note that most of us over the course of our careers, the advocacy we will do will mostly impact individuals. So if you think about that, that's identifying the gap for the patient in front of you and your work to ameliorate that. At the very outermost ring, we've labeled structural advocacy. And in that case, the outcome of the advocacy is a change such that the problem you encountered is largely gone. So whatever problem your patient experienced, if you have put in place a structural change, the idea would be if that person or someone just like them encountered the same problem, they would have a very different outcome because you've changed the rules, you've changed the policies and procedures such that a more just outcome occurs. In between that is a layer we've called relational advocacy. So if you think about that often an advocacy effort may involve a larger group, a larger maybe a local institution such that a larger number of people would be impacted by the changes that come about, but it falls short of a full structural change such that as you get further out from the community of action that the change is less likely to be relevant beyond that. The next thing I want to take your attention to are the hexagons. They're meant to represent lug nuts. And I'll start with the P, which is for practice. So most of us will locate ourselves in practice. This is the institution, the clinics, the place where you work every day. And I want you to think about those places as places where change can occur, and often the results or the action of your advocacy may need to go no further than this. So if there are policies in place in your home institution that are resulting in poor outcomes for your patients, then perhaps just working in the context of your practice environment may be all that's necessary. For other changes that might be necessary to get the desired outcomes, you may in fact have to involve the community, which is represented by the C. So think of that as the individuals and institutions adjacent to your practice, adjacent to your patient or your patient's family. And then the G, government. So think of everything from the local school board up to the Congress or Supreme Court of the United States, all the regulatory agencies in between. So anything that involves anything that would be called a government activity. They're all represented as hexagons or as lug nuts because change doesn't occur without pressure being applied. And so you'll see at the bottom a wrench. And the idea is the 3 things on the wrench are what you use to apply pressure to bring about change. I want to start at the far right, so policy. Most of the time when we use the word policy, people think of policy with a big P. So they think about policy as laws, as regulations, as things that are often highly codified and highly complex and that require a great deal of procedural effort to change. But I'd like to broaden your thoughts about what policy is. So policies exist in our practices. Sometimes they're written down, and sometimes they are very informal. Policies often are enforced by individuals or just by common understanding. So think of policies you yourself have. So you have policies about how you get up in the morning, how you get to work, how you engage with things, as do your patients. So think about policy simply as an established way of doing things. And we're going to come back to that later when we think about the change you'd like to see happen. But there are a lot of policies that, in fact, are very local, informal, and the decision makers may be a single individual, all the way up to policies which are covered in statute and require much more formal action. The middle is relationships. So there are policies you can change with a single relationship. If you are on good terms with the medical director of your practice, that may be all that's necessary to change a policy in your clinical environment. If you want to enact a structural change, you are going to need a lot more friends, and you're going to need a lot more relationships. And so one of the things we'll talk about here is thinking through who those people are, identifying key stakeholders that are necessary to move policy. And then the final piece of this is communication. So in the terms of change, you need to be able to describe the policy that is the status quo, the way of doing things that's the standard way of doing things that creates the challenge that's of concern. And you need to be able to describe the future state. So what would a new policy be if your wildest dreams came true? What would be the change, and how would you describe it? And you may describe that very differently depending on the medium in which you're going to communicate, the people you're going to communicate to, but you need to think through how do you create that message and craft it. Because of the limitations of our time today, we're not going to spend a lot of time on communication and on developing messages, but want to put that in front of you today as you think about the work ahead of you, because it's a pretty critical piece. So I will pause there, and I'm going to look to see if there's anything in the chat. And why don't we go ahead, and if you do have questions, please send them into the chat.
And I'll continue from what Mark was saying to fill in the details of how do you think about who are the people you want to develop those relationships with and communicate with in terms of the details of how you apply that wrench to the lug nuts in the advocacy framework. And so, you know, for this first bullet, I first want to reemphasize what Mark said, that there's policy with a big P, which is some of the laws and regulations we frequently think about in government. And there's policy with a little p, which I don't have in this bullet, but that could be anything from practices in your you know, local clinical area or health system, et cetera. But what I encourage you regardless is to learn about it. So if it's policy with a big P, read the bill, read that regulation, read that court case. You are capable of doing that. I think oftentimes people get intimidated by that, saying, you know, I'm not somebody who's done that. I'm not in government relations, et cetera. But everyone in this audience is extremely smart, intelligent, and used to reading the literature. So this is just a different type of literature. I will also say many places, including most health systems, have a government relations officer or staff person. And so you may not know who they are, that they exist, but that's another person you can reach out to help you understand those details. The next thing I want to say is once you figure out what that policy is, whether it's the big P or little p, it's important to brainstorm who are those people you want to develop those relationships with. And in our parlance, in our policy engagement team, we refer to them as policy stakeholders. So that could be anyone from your practice medical director, as Mark said, to if it's government, thinking about which branch of government do you want to influence? Is that the legislature because there's a bill there that you think would be aligned with what you want to see in the world? If so, who are the people that you want to target in the legislature? Is it the executive branch, whether that's state, federal government, or even county and local? Who is in that administration? What are the regulations that they have in place? And increasingly, we're seeing actually a lot of action in the courts. So sometimes it's in the judiciary, a court case that you need to go a certain way to get the change that you want to see in the world. I will also say Sometimes they're the people who are the targets of who you want to apply that wrench to, and then there are the kind of allies who help you do that. So thinking about advocacy organizations, thinking about your professional societies, including SGIM. This webinar is hosted by the Health Equity Commission, which puts together a lot of important information and tools to help. There's also the Health Policy Committee. There's various kind of different committees and groups within SGIM that can help you in your advocacy or policy engagement work. I think the next step is really engage that policy stakeholder. And once you've identified that person or those people, figure out, do a little homework. What is their current position? Maybe they don't have a position, or maybe they've taken a position before, but you'd like them to move more in that direction. There are a lot of different ranges of how you can influence someone, but it's good to know where you're starting with. And then if there is precedent, think about the relevant precedent in this area or even relevant research. So I think we'll see a great example discussed today, but think about what are the previous state laws, regulations, court rulings, what are the current practices if it's policy with a small p in your health system, whether that's written down or not, who are the people who have established those? It's kind of the same homework you would do for anything, except in this case, learning about these individuals that you've established as policy stakeholders. And if you could go to the next slide. The next key is we're not going to get into a ton of detail about the specific communication strategies, but I just wanted to talk briefly about framing. You know, when you're thinking about who to target, I think it's important to figure out where is that change you want to see. Is that at the local level, as in your health system and your community? Is that at the state level, at the national level? I think that helps frame what types of engagement or advocacy you would like to do. And the other thing I want to say is, you know, building those relationships is really important. Engaging those policy stakeholders early and often is key. So you may not have a relationship with the people who are the ones you want to influence. But as you develop that, don't just see this as a one-off opportunity to see the change that you want to see, but as developing an ongoing relationship that may be someone you go back to with other issues that you want to bring forward. So, you know, Mark gave the example of the medical director in your practice. There's probably a lot of things that will come up over time that you want to see change in the practice. The same goes for community, state, and the nation. And then, you know, thinking about how to tailor the message to your audience, there's not, we're not going to go into that detail, but just think about how does that person view this? What kind of language do they use? What kind of language should I use so that they can understand? And that may not be medical jargon if they're not in clinical medicine. I'm going to pivot in a moment to talk about issue briefs, which can be one effective tool to communicate and are very different than what we're used to seeing often, like here's an academic paper or here's a long review background on something. So I'll go into that in a second. And just as I said before, just underscoring, continuing to engage and develop those relationships with stakeholders can really help you not only with the first change you want to see in the world, but many others hopefully going forward. Next slide, please. So I wanted to just give you a couple of examples of what issue briefs may look like for different audiences to just kind of make a concrete example. What do I mean by who's my audience and how would I communicate with them? And if you go to the next slide, I wanted to give you two different examples of briefs that I made for different audiences and in different modes. So this first one is a brief I made in a Word document without anything very fancy and copying and pasting in some images. And this for me was a way of engaging my State Department of Health and Human Services. The background on this is that it was during early, I started this study early in the state's Medicaid expansion, and I wanted to see how well they were doing. And I wanted to see if there were certain areas in terms of primary care providers and physicians and non-physicians who were accepting new Medicaid patients, and whether there were certain regions of the state that maybe the State Department of Health and Human Services needed to target more and do outreach to those communities. What you'll notice off the bat is that unlike an academic paper, the first thing you see on the top left here is the key finding. And that's the other thing that you would see there, depending on whether this is policy engagement for research or advocacy, would be your ask. So if this is something you know, you're talking to somebody and you want them to do something specific, that's where you put your ask for them, because that's what they expect to see. What do you want from me? And then they'll get into the background of what's there. There's a brief background. The entire brief is no more than 2 sides of a page. And then it gets right into, in this case, research findings that I want them to see. And in other cases, it may be recommendations that you have. what you'll notice is that since this was for a Michigan statewide audience, I put maps here, and that was very powerful, and they're organized by regions that the state government divides the state into. And so this was really important. That's the way they're looking at things in their dashboards, and to make it in a way that they're used to seeing. So that's just one example, very easy, and just highlighting again, the ask if it's advocacy, or the key finding if it's engaging your research into the policy world is right at the top. Next slide, please. I just wanted to give an example of a different brief of the same exact thing that I was trying to engage with, same exact study. In this case, it's glossier because my institute put it together, but I could have done the same thing in a Word document that looks fine, and policy stakeholders would still be interested in it. One thing you'll notice is that the Michigan maps aren't on here because it's a national audience. So we highlighted different findings for a national audience that, that we thought they'd be more interested in. It's still 2 sides of a page. And it starts with, in this case, the key finding, but again, in advocacy, I would say that would be your ask for that policy stakeholder. So just 2 different examples of how you might tailor your message. The key being, put your ask or your key thing you want to say on the top, keep it short, and try to figure out what are the things you want to say or show depending on your audience. Please go ahead. So a few take-home messages on policy engagement. We said it before, but just saying it again, engage your policy stakeholders early and often. Actually read the policy you're interested in. If it's written down, that is, both big P and little p, read that, health system policy, read that bill, court case, that regulation. And if you're looking for ways to communicate, one tool can be issue briefs, because most policy stakeholders will not read an academic paper or a long review. So you want something brief and pithy to translate your findings. And lastly, developing relationships with policy stakeholders over time does take time, but it can reap huge benefits for seeing the change that you want to see in the world. Please go ahead. Take it away, Lily.
All right. I want to start off my section by thanking the patients and stakeholders that were part of everything I'm about to describe. Because honestly, if it weren't for this incredible group of patients and stakeholders, none of what I'm about to describe could have happened. I'll start with my advocacy problem. And as many of you know, it's emergency dialysis. Hilda, the woman that you see pictured here in the middle, was an undocumented immigrant mother of 2 elementary school-aged boys, and she had kidney failure. I got to know her really well because I was a full-time clinician, hospitalist at the time, and saw Hilda on a weekly basis. In Colorado, and this was before February 1st, undocumented immigrants had to be literally at the brink of death to receive dialysis. And so Hilda would come to our hospital about every 6 to 7 days for emergency dialysis. And after about 2 years of emergency dialysis, Hilda had suffered 3 cardiac arrests. She had heart failure and several other problems because of poor access to care. And her boys were suffering tremendous psychosocial distress because they didn't know each week if their mom would survive to the following week. They weren't going to school. They were scared to leave her side because they didn't want her to have another cardiac arrest and no one be around to call an ambulance. And so Hilda, after some time, decided to withdraw from dialysis. She knew that her days were numbered and she didn't want her boys to end up in the U.S. foster system. And so a group of us provided her with some support. We started interviewing families. And when she found the right family, she stopped emergency dialysis and passed away on Mother's Day in 2014. And when Hilda passed away, for me, watching her on a week-to-week basis, it was just very morally distressing. But after she passed away, I just couldn't go back to work and continue doing the same. And so I decided at that time that I would move to research or transition to research with the sole purpose of changing health policy. And so just very briefly to give you an idea of what it's like at Denver Health, or was like at Denver Health, there were about 70 to 80 patients, and they would come in every 6 to 7 days through the emergency department or the urgent care center. They would all have a set of labs, vital signs, EKGs, and if they were critically ill, then we would admit them to the hospital. They would receive dialysis on the day of admission. They would stay overnight, receive a second session of dialysis, and then repeat the cycle again 6 to 7 days later. Because we were seeing an increase in the number of patients and we had limited dialysis chairs, we oftentimes had to turn patients away and base admissions solely on the potassium. And that was really hard for us as clinicians to turn people away when they were visibly ill. Nationally, there are about 6,000 to 9,000 undocumented immigrants with kidney failure. They tend to be Latino, and they tend to have resided in the U.S. for at least 5 years before being diagnosed with kidney failure. As many of you know, the standard of care for patients with kidney failure is kidney replacement therapy. And that's typically through kidney transplantation or peritoneal dialysis or hemodialysis. And this is something that's available widely for U.S. citizens because of the 1972 Medicare entitlement program. However, for undocumented immigrants, benefits sort of vary throughout the country, and their care, well, I'll describe their care, but many don't have access to care. I'll briefly actually go over this timeline and give you an overview of healthcare legislation as it relates to care for undocumented immigrants. In 1962, the Migrant Health Act included primary care services, and this ended up with the creation of several of the federally qualified health centers. And then in 1965, the Social Security Amendment established Medicare for older adults as well as Medicaid for lower income individuals. And because it didn't directly address the availability of benefits to non-citizens, many interpreted the statute to allow coverage. However, in 1986, the Omnibus Reconciliation Act explicitly prohibited immigrants from public benefits like Medicare and Medicaid. And then that same year, the Emergency Medical Treatment and Active Labor Act prohibited refusal of care in an emergency situation to anyone, regardless of immigration or insurance status. And so that essentially created the emergency Medicaid programs. And then the Welfare Reform Act of 1996 further restricted immigrant access to public benefits. It required that immigrants such as green card holders be in the U.S. 5 years before they could receive benefits. And then many of you are familiar with the Affordable Care Act. That one also excludes undocumented immigrants, and so they cannot sign up for private health insurance on the marketplace exchange. And then finally, the public charge rule change, which further restricts access to care because it weighs any use of cash and non-cash assistance against applicants for permanent residency. And so in summary, because undocumented immigrants are excluded from Medicare, most Medicaid programs, and the provisions from the Affordable Care Act, they end up relying on dialysis through the Emergency Treatment and Active Labor Act. And so basically they end up having to go to an emergency department and being critically ill to receive dialysis. And so I just want to read off this federal law. It basically states that emergency Medicaid may be made to states when care is for a medical condition that manifests itself by acute symptoms of sufficient severity, such that the absence of immediate medical attention could reasonably be expected to result in placing a patient's health in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any bodily organ. And so essentially this is the federal law, but as I mentioned, this led to the creation of an emergency Medicaid program for each state, and each state manages its own emergency Medicaid program. And what isn't widely known is that the Office of the Inspector General and federal CMS provide no sub-regulatory guidance that defines an emergency medical condition, and so they actually defer to states to determine those qualifying conditions. And so in Washington State, for example, they've modified their emergency Medicaid program to include treatment for dialysis, anti-rejection medication, anyone that needs a cancer treatment or outpatient surgery. And throughout the country, as you can imagine, this leads to sort of a patchwork safety net for undocumented immigrants. And so back in 2019, we looked at the emergency Medicaid definition and provider manual. We looked at basically all the language around dialysis and found that there are a handful of states, those states that you see in green, that provide Medicaid reimbursement for standard dialysis for undocumented immigrants. And those states that you see in orange are where there's sort of variation in care. So some cities offer it or some hospitals offer it, and care is not reimbursed through Medicaid. There's other sources. And then those states in red are where undocumented immigrants continue to rely on emergency dialysis. However, I will say that because of the research and this work, some of those red states have turned green, which is really exciting. And so, as I mentioned, after a lot of soul searching, after Hilda passed away, I decided I needed to do something different because this had to change. And so because my transition was focused on changing health policy, I decided to begin engaging stakeholders early on, and then, as you'll see, sort of throughout the process. I started by engaging patients. I wanted to understand their perspectives because up until then, all of the narratives that had been written were written by clinicians, and I wanted people to know what patients felt and what they were going through. And so as I brought patients together in focus groups, they formed their own peer support program that they called Club Riñones Latinos, and then they formed their own Facebook group so that they could support each other and support other undocumented immigrants throughout the country with kidney failure. And they also joined me in research, and so this is a qualitative study where I interviewed 20 undocumented immigrants one-to-one, recorded the interviews, and then analyzed them thematically. And what I found is that patients were suffering from significant physical and psychosocial distress. And a lot of it was from the symptom burden, because as I mentioned, patients would come in, receive 2 consecutive sessions of dialysis, and then couldn't come back until 6 or 7 days later. And so as you can imagine, they felt good for maybe 2 or 3 days after the dialysis, and then were just waiting for all of their symptoms to accumulate so that they could come back and qualify for another session of emergency dialysis. The other thing that patients described a lot was risking death, because many of them, rather than risk being rejected by the emergency department because they weren't sick enough, would oftentimes consume something high in potassium just outside our hospital doors, knowing that they were risking going into cardiac arrest in the waiting room, but they just wanted to receive the care. And then I also connected with caregivers. The caregivers also joined us in all of the advocacy work, which is really incredible, and in the research. I met with 20 caregivers and learned from them that they were suffering a lot of death anxiety because they worried that their family member wouldn't survive until the following week. And found that many of them also had children, and many of their children were dropping out of school or missing school because of their loved one. And then finally, I engaged interdisciplinary clinicians, and they also joined in a lot of the advocacy and media and stakeholder engagement. But what I found from clinician stakeholders is several drivers of burnout, including emotional exhaustion from witnessing needless suffering and death, jeopardizing patient trust because they had to turn patients away sometimes, and then this need to detach themselves from patients to numb how they were feeling. And they also felt morally distressed because they felt like they were propagating injustice. And as Renu mentioned, in engaging some of the health policy stakeholders, I learned where there were research gaps and important questions that we could ask from the research to inform the health policy stakeholders. And so in one study, we did a retrospective cohort analysis looking at differences in mortality and utilization between undocumented immigrants that receive standard dialysis and undocumented immigrants that receive emergency dialysis. And in this study, we found that 5 years after starting dialysis, patients have a mortality that is 14-fold worse, and utilization was 10-fold greater. And we also connected with opponents because it's really important to understand the perspectives of the people you're connecting with, regardless of which side they're on, and understood that the two most important counter arguments were that by expanding care, we could increase immigration to the U.S. for healthcare purposes. And people were also concerned about the cost of providing dialysis. And it was important for us to understand these two because little by little we were sort of able to chip away at answering some of these questions. And so we were able to document that most undocumented immigrants with kidney failure in the country have lived here for at least 5 years. And in a couple of states where they had expanded access to care, they did not see an increase in the rate of people initiating standard dialysis that were undocumented. We also did a cost analysis that showed that there was a huge cost savings when patients transitioned to standard dialysis, and used research previously published by Dr. Zalman showing that undocumented immigrants can contribute a surplus to Medicare. And so just to summarize, as Mark and Rainu mentioned, the beginning of this work is really engaging various different types of stakeholders. And I think I just want to stress that one of the really beautiful things to have seen in this research journey is the engagement of this coalition with media and with the health policy stakeholders. Oftentimes when media reached out, they wanted to interview patients, and the patients and their caregivers were always excited and willing to be interviewed, even though they're undocumented. And oftentimes, I would send a WhatsApp message saying, who's available to be interviewed by CNN, or who wants to go, downtown and meet with such and such stakeholder. And the number of people that were excited to join us was just incredible. And so it really just felt like a team. The second thing I want to mention is gathering the data. The qualitative interviews were really important. And so for any of you considering qualitative research, it's important because you get the narrative out there, the patient stories, and those were the stories that the media really wanted to sort of, spread, I guess, because they resonated with the public. Important to this particular issue was doing a policy analysis here in Colorado. And so that helped us to really be more strategic. It helped us understand that state legislation was going to be a long process and unnecessary. We found that CMS approval was not necessary because they defer to states to determine the qualifying conditions for emergency Medicaid. And we also found that state regulation was not necessary because it would have involved a lot of stakeholder engagement and a vote, and really all we needed to do was to make a state billing policy change or sub-regulatory language change. And so with that, as I described, this type of care was extremely distressing to so many of us. And after 5 years of advocacy, stakeholder engagement, and research, Colorado Medicaid decided to include the diagnosis of end-stage kidney disease in our emergency Medicaid program for our state. And so the change was made as of February 1st, 2019. And the boys that you see pictured here are the same boys that were in the picture with Hilda. So these are the boys now. And I'm just excited to share that one of our boys just graduated from high school and he's off to college, and they're both doing amazing. And so I'll pass it off over to Mark.
So before we go on to the next phase, as an interested but somewhat outside observer of the story you just heard, I want to, I think often successful stories look very linear when they're told in hindsight. And I want to offer up a couple of observations. One of which is the importance of Lily's firsthand witness of her willingness to speak the truth, and basically the fact that her moral distress didn't stop with her in her home. So I think often we've all been part of these conversations where we gather a group of friends, we sit around, we talk about how awful something is, we comfort ourselves enough so we can go back tomorrow and do it again. And the difference here was, in fact, Lily's willingness to go out and say, no, really, you need to listen to me. This shouldn't be this way. And while it sounds really clear, the sort of the end point, there was a long process of starting with people at Denver Health to say, couldn't we here just take care of these people by ourselves, sort of starting in that practice section. And it turns out actually that emergency only dialysis was actually very profitable for the hospital. And so not only was it gonna be difficult to do that locally, and then what you saw the group of patients there. What I saw basically was Lily and her persistence and the clarity of her voice, both sort of morally and if you know Lily, you know how hard it is to say no to Lily and how easy it is to say yes. The group sort of grew around her, and as that happened, people they wanted to be part of this, and they wanted to be part of change, and doors started to open and pathways became more clear, and there were still some starts and stops to sort of make room for politics, but at the end of the day, by being able to tell the story, develop the data that you saw, and persist, the outcome occurred. And I'm going to ask Lily, what it was probably 4 years from start to finish. Is that a correct timeline?
Yeah, about 4.5 years.
There are two questions in the chat to you, Lily. So one, were state lawmakers more persuaded by the economic arguments versus the moral arguments? I.e., if it weren't cost effective, isn't it the right thing to do still?
That's an interesting question. So what's interesting is in the hospital, as Mark mentioned, there was definitely incentive to continue this type of care. What I forgot to mention is that each time a patient was admitted for emergency dialysis, the DRG reimbursement was about $6,200 per person per week. And, compare that to Medicaid reimbursement for standard dialysis, which is about $700. And so the cost argument was extremely important for health policy stakers, but also internally within our hospital. I found two incredible internal stakeholders, one being the chief finance officer. So believe it or not, our hospital made millions from this type of care. Yet she was willing to step forward and say, this is not the type of care that we want to give. And so despite this cost incentive or, incentive from money, she wanted to do the right by patients. And so the cost piece was important. But at the end of the day, at least internally, what moved our hospital to really push for this change was wanting to improve care for vulnerable patients.
And Lily, as a follow-up to that, just looking at there's a great chat going on. Can you please discuss how much the cost and how you did the cost analysis a bit more? With whom did you collaborate, et cetera?
Yeah, so internally at Denver Health, there's about 120 patients in the state of Colorado that are undocumented and with kidney failure, but 90 of them, so the majority, are at Denver Health. So the cost analysis we did was within Denver Health. So basically comparing undocumented emergently dialyzed patients to documented Medicaid patients. And that's how we did our cost analysis.
And then a couple of questions here. Lily, were you able to find people who started as opponents who became allies? And I think related to that, there's a great question about the strategy, the way that you started your research from the patient perspective to the clinical perspective to the empirical quantitative research. Was that part of your long-term advocacy plan in the beginning, or did you figure that out along the way?
I think I figured it out along the way. My first goal was, what are patients going through? And then as I connected with the patients, and then I moved on to the caregivers and then the interdisciplinary stakeholders. And each time one of those studies was published and the media shared it, it sort of allowed us to share this experience with a wider audience, and more people would reach out and connect. And then ultimately we were connecting with community-based organizations and health policy stakeholders, and then that grew. And so it was kind of like a domino effect. But I have to be honest, like, I was not this smart in 2014 when I started this. I didn't know all the different stakeholders that I would need to engage.
And then I'm happy to answer a couple of great questions here. I feel sort of bad about this one. Your beautiful figures are very intimidating from the issue briefs. Any advice on who we might work with as docs/researchers to help share the message in that creative way? And I was hoping they would be inspiring rather than intimidating. So to start, at almost every health system, hospital, or other large organization, there are people who focus on government relations, and there are people who focus on media and communications. And I never knew that until I started this process, and it's so great to collaborate with them. And just to link in the other question here, in regard to the issue briefs, how did you know ahead of time how the policymakers view their data? For example, how did you know they view the maps that way? How did you know they would understand it? And so some of that understanding comes from working with those folks who have been in that process of knowing who the stakeholders are and engaging with them for many more years than me. Some of that process was the do your homework part of, knowing that for that brief, in particular with the maps, my target audience was the State Department of Health and Human Services, and I wanted to talk about local regions. So I said, well, how do they organize this? I go to their website, I talk to them. They divided the state into these 10, what 2 governors ago called the prosperity regions, to align all the different branches of state government. So I knew they were looking at all these maps that way. In terms of creating issue briefs, I would say it can be glossy working with those government relations and communications people. But at the end of the day, I created that first one with minor help from one of my research assistants at the time on a Word, like a Microsoft Word document, and copied and pasted in some figures that I had made in PowerPoint. So I don't think it needs to look very polished to get the right information in front of the stakeholder that you're trying to engage with. I also want to highlight, because Lily's story still gives me chills, it's the data plus the stories that really move people. So whether the stories are this powerful qualitative work like Lily did, or it's your personal story of the patient in front of you, of your family member, of even you, that plus showing the data that that they're most interested in is really the most powerful that I've seen.
And Lily, one more question back to you. So there's a question here about understanding how somebody without Medicaid has emergency Medicaid and how that is profitable. You want to take a sec just to explain that?
Yeah, so as I mentioned, the emergency Medicaid program is sort of separate from regular Medicaid and created because of EMTALA. So basically anyone that walks in through the emergency department and needs emergency medical services is covered by emergency Medicaid, whether they're undocumented or whether they have health insurance or not. And all of it is reimbursed by the regular sort of DRG Medicaid program. And most of these patients end up falling into a DRG of that includes hyperkalemia. And that particular DRG ends up having a reimbursement of anywhere between $6,200 to about $8,000, depending on the location of the hospital. And so that's how it's different, is that this is using emergency Medicaid for an emergency medical condition. And that's essentially why patients have to prove in some way that they're critically ill when they're presenting in the hospital. And so we have to use these certain objective criteria so that our hospital is reimbursed for emergency Medicaid.
And then there's a follow-up to that. So even if they've done nothing to apply for Medicaid, still billable to Medicaid by the physician. And the answer to that would be yes. If they qualify for emergency, if the condition qualifies for emergency Medicaid.
Mm-hmm.
So a question for Marshall: Is there a process in picking the right story? I'll briefly offer my thought on that. Often you have the stories that you have. You can go looking for others, and I think in general my experience has been to try to look for the themes that come as close to universal as possible. So things that strike to fairness, things that tend to I think one of the great things about Lily's, the stories she gathered, is one, at the heart of it is just a story of a mother and her kids trying to get along that everybody could relate to, and the layers around that are this sort of absurd economic pieces that even your most sort of curmudgeonly dollars and cents kind of person would say, why am I paying 10 times more to make this person suffer than it would be to make their lives better? But Renu and Lily, I'd ask you to think about what do you think of when you construct stories, or choose stories, I'd say, as opposed to constructing them.
You go first, Lily, since you've had these very powerful stories just illustrated.
No, I end up choosing the stories that draw me in most. And I think that's why, with Hilda, I was so inspired by her because every decision she made putting her children first. And she was young and she was suffering, and she ultimately decided to put them first by putting them up for adoption. And so I think it's those very moving stories that will move others to join your coalition in changing and in advocacy.
And the only other thing I would add is choose the stories that you can speak most honestly and passionately about. When Lily tells this story, it stops you in its tracks because of how strongly she feels about it. And so in my past, I had done a lot of legislative advocacy, and we kind of talked about how we communicate similar to the issue brief, but we called it message in a box, where basically you have, this is my ask, here are my 2 to 3 supporting points, and here's how we close, saying we're going to continue this relationship. And always in the 2 to 3 supporting points was at least one moving story, whether it was something that happened personally to me or one of the other people I was with, to their family, or to patients they were seeing. And I think we do have that strong voice as physicians to say, this is not only a powerful story, but this is how I felt caring for this person. And as Mark had commented on Lily's story, that moral distress or that moral concern, we do still have a role in society to elevate moral concerns. And I think that's something that we have, that's a very powerful voice compared to other stakeholders. So that's the last thing I would highlight there.
And one more comment in the chat, or question. First, the comment that it is indeed a powerful story you told, Lily. But the questions, in what settings do you start with a story? And as clinicians, do you always start with a story?
I always start with Hilda's story because it's what inspired and moved me. How about you guys?
I think one of the key parts of being effective as an advocate is being able to tell the stories of the people we care for. And the truth is we circulate in circles where people they don't see what we see, and they don't meet the people we meet. And I think it's very important that we take our privilege and as a friend of mine used to say, afflict the comfortable. That we tell those stories and make people squirm a little bit with the reality of the world they live
I couldn't have said that better. Yeah, when I've done my individual groups, we've always started with someone's story because you want to draw in the person you're talking to, or the data or other facts that you share won't really stick at all.
And I do want to call out this the comment that just came in, that so much of burnout is from moral injury and not lack of resilience. And one of the questions I often get asked by early learners is sort of the cost of speaking out. And I like to talk about the cost of not speaking out, because I think to your point, Lily, and I think you illustrate this so well, so many of us have the choice you can do something, or you can just decide to sort of swallow it and go on. And I actually think that to this point, it is cathartic to speak out and to tell these stories, and it is costly not to. And I think that's one of the things I think it's really important to convey to our learners.
Mm-hmm.
Well, let us. We're right on time, so let's pivot here, and we're going to have you all convene in small groups, and hopefully each of you at this point has identified the issue that you want to talk about, or not so much talk about, but you want to work on. And what we're going to ask you to do is in these 5 bullets. So, describe the status quo, the problem as a policy. So what is the current way of doing things that you would like to see change? Describe the change you would like to see as a policy. Identify who can change that policy, and potentially how such a change would come about. So what's the process by changing it? And then we're not going to have you talk about this, but I want to just put this because we're going to run out of time. But think about who the key allies and opponents would be. And then we're going to have you each talk to your small groups and about that and receive feedback. So you're going to have about 20 minutes to do this. And then you'll get the little notice that you have the 1-minute warning, and then we'll all be back together again as this is right now. So if you'll hang on just a second, Dawn will transport you into your small groups.
And anyhow, with that, I just want to thank everyone for joining us this evening. I know that it's nighttime on the East Coast, 7 p.m. here in Colorado, so we've still got some daylight. And, this time is really hard for everyone, but I think finding ways to tackle burnout sometimes by tackling certain issues can help. If you can find motivation and meaning in certain things and really tackle them, it can be helpful, I think, during this time, or at least it is for me. But anyhow, thank you so much for joining us. And I'm on Twitter. Feel free to reach out anytime. And we've got more webinars coming up, one on homelessness, one on undocumented, and then other equity issues around COVID as well. So thank you, everyone, and have a good evening.
Yeah, thanks, everybody.
Thank you, everybody.
Thanks, everybody.